Happy Thursday, April 2nd. I'm really happy to have my husband, Art Pancioli, Chairman of Emergency Medicine at UC, with me today. So I'm going to run through how we always do this with some statistics and a couple comments, and then let him do some talking and take your questions. So yesterday I predicted that we'd be over 1 million cases today. We're actually at about 992,000 right now, so not quite 1 million. Global deaths are up to 51,000. In the US, the numbers have jumped quickly, 234,000 with 6,000 deaths. In Italy, and it's become a competition now, which is growing faster, and who's going to win between Italy and Spain. So Italy's at 115,000 cases, if you can imagine. If you think about that, the size of Italy compared to the size of the United States in terms of population, they're at about half our cases, and they are at about 1/10 of our size. So that is just staggering for them. They are at 14,000 deaths, and again, that compares to our 6,000 deaths at this point. Spain is 110,000 cases, so they're neck and neck, Italy and Spain. Now my guess is Spain is several days to a week behind Italy, that they will surpass Italy at some point. The deaths in Spain are 10,000, and again, much like Italy, the decimation to the healthcare system is just terrible. So back to the US, 234,000, so 93,000 of them are in the state of New York. We've had 2,600 deaths in the state of New York. So again, when you're thinking about the 6,000 US deaths, New York itself is almost half. So it's terrible. New York is in really a crisis. And to put that in comparison for you in terms of other states, New Jersey is the second state in terms of the number of cases, and they're at 25,000. California is the third, and they only have 10,000, and Michigan is the fourth with 9,500. So you can see the gap between 93,000 in the state of New York and 25,000 in New Jersey, the neighboring city, and you can see just how significant New York is in terms of being the epicenter. New York City itself has 50 of those 93,000 cases, so again, well over half, and the death in New York number of deaths is 1,400. Florida is now the 6th highest state with 8,000. There's been 128 deaths in Florida. All right, jumping to Ohio. Again, I say this every single day, but I think really largely due to Governor DeWine's early stay-at-home policy, our rate of increase is staying around 300 a day right now. So we went from 2,600 to 2,900 today. Our deaths jumped from 65 to 81. We have 802 patients in the hospital. And what I want to point out to you is that is 28% of the patients that we are aware of that's positive. Now, again, that really probably artificially elevates the percentage, because right now we're really only testing the majority of those people who are very sick and in the hospital, but still that's a very high percentage of people requiring hospitalization. We have 260 patients in Ohio in the ICU, which is again right around that 9% range. The mean age is 53. So again, although elderly people are certainly most susceptible, the median age really is only 53 in the state of Ohio. So talking about that great data, those curves, and you should all look at them yourselves because I think it's a great site, the IHME data we talked about yesterday. So if we look today, remember that the more data you feed into that system, the more accurate your predictions are. So yesterday for the US, they were predicting the peak was going to be April 16th. That's actually modified now, and the peak's going to be April 15th, they think. We're going to need 262,000 hospital beds, which is an 88,000 hospital bed shortage, 40,000 ICU beds, and they're predicting a 20,000 shortage and 32,000 ventilators. The maximum death rate, 2,600 people a day, with a total death rate, again, peaking on August 4th at 100,000. In New York, again, hospital beds, and this is just the terrible crisis that they're in, 76,000 will be required, with a bed shortage of 63,000 beds. ICU beds of almost 12,000 with a shortage of 11,000. I mean, these are just staggering numbers, and 10,000 ventilators needed. They think in New York on August 4th, the maximum death will be 16,000 people in the state of New York. In Ohio, good news for us again is that I think what Governor DeWine has instituted, and that's been now extended to May 3rd, that we really have flattened the curve. And the good news for us is I do not believe in Ohio we will be in the same position that New York is in. 67 hospital beds they estimate will be required, and we will have adequate hospital beds, 1,000 ICU beds, and we will have adequate ICU beds. 800 ventilators. And so it looks like, again, the onslaught is coming. The date, again, is still at April 19th. But it looks like, again, if we continue with our social distancing, that we will be okay. So Governor DeWine extended the stay-at-home policy in the state of Ohio until May 1st. The good news is it looks like we're on track, both what Dr. Fauci said last evening and what I've seen today, for really anticipating a vaccine sometimes in 2021. So that's really great news. And the other good news today, the FDA approved the first antibody test through their emergency use authorization. And this is an antibody test for both IgM antibody and IgG antibody. The test that was approved today for use during this time is a blood test, and the blood has to actually be sent to a lab. There's a lot of tests now that are also looking for approval through the same emergency use authorization, where it's a pinprick to detect antibody levels, and that's coming. I think if you heard the press briefing last evening, really quickly doing these kind of tests, so they'll be available in physician offices and immediately in the hospitals for rapid, quick tests like a pregnancy test or a flu test, are coming faster than we anticipated, and hopefully in the next days, weeks, months, we will have those more readily available. And now I'll let you go.
Well, that's a great summary. And indeed, the stay-home policy does look like it's having an effect. The rate of rise is hopefully curtailed. That doesn't mean a lot of water is not going to come over the levee. So we still are doing an enormous number of things to ramp up for what will be a very large demand of medical care. Some of the stuff that's going on, here in Cincinnati, we really haven't seen anything of our potential right now. In the health system where I work, we're at just over 5% of our tests are positive, and that is despite the fact that we're testing more and more patients who are being admitted and or in the emergency departments with the anticipation of going upstairs. That's still a relatively low prevalence. We still don't know what it would be if we could test everybody in the community. There are undeniably asymptomatic patients out there who have COVID-19. There are undeniably patients with very mild symptoms who have it. We're hoping they continue to stay at home. The slower the group gets exposed, the better, right? It'll give us a better chance to handle the surge. Along the lines of surge, all of the hospitals in this region have been doing a really good job of emptying out and getting ready. We have a tremendous open capacity right now that will likely be eclipsed or will certainly be. But again, leadership at the state level and leadership within the health systems in and around Cincinnati undeniably have led to a better, vastly better preparation than some of our dear friends in other larger cities like New York, which is, from all reports, absolutely terrible. It is hitting our city. We do have inpatients at many of our hospitals. It's in the neighborhood of dozens. It's not in hundreds. There are probably a dozen inpatients in our ICUs in our health system, about a dozen, but that still leaves a significant capacity. The problem is, imagine when things start doubling, right? It becomes a very quick problem. In order to solve that problem, every system around is creating their surge capacity. I have been so impressed with some of the leadership that I work with, and specifically some of the physicians in our department who have taken the lead in preparations and planning and helping to create a really robust cascading plan for surge. And what it means is you have to be able to advance where you put sick patients, right? You have to advance the teams that are ready to care for them, and you have to have the stuff that you need. And that's going on at all of our hospitals and our health systems. And some of it's just some marvelous work, very thoughtful. And the volunteerism of effort that I'm seeing is if you could see it, you'd be just so proud. And I am. I will tell you also that the Cincinnati Health Collaborative, in concert with local government, at the direction of the state, and with the use of the National Guard and FEMA, is looking to create an alternative care site. The discussion is currently around the Duke Energy Convention Center, a very large place. So what do you have there? You have the place, right? Now you have space. What would you need? Then you need the people. So then the large healthcare systems say, okay, a lot of clinicians right now aren't doing outpatient work, aren't doing elective work. These are doctors. In concert with those who do emergency medicine and critical care, as we do every day, and under the guidance of one of my faculty, they'll look at creating the people, and then you have to get the stuff there. And you say, okay, well, that's all well and good, but what about transport? How do the patients get there? How do they go from there to hospitals if they need to, or hospitals to there if they need to? Transport's going to be an issue, and it's something that's being aggressively looked at. We've had those discussions already today. If I could just describe for you the number of emails, texts, communications, rapid thought processes, writings of standard operating procedures, educational ideas of how we're going to teach each other the different things we need to do. The energy that's being put into this is like nothing I've ever been part of. I don't ever really want to be part of it again, but it has been absolutely unparalleled in terms of cooperation across every boundary that used to be in our way, across the health systems, transporting back and forth information with our local and our state government. Really, truly, ladies and gentlemen, I will tell you that this is a crisis. Y'all are doing your part, and the healthcare systems are doing theirs. Will it be enough? I don't know. Is it Herculean? Undeniably. And is the work that's being done truly inspirational? If you saw inside the rooms where the work is being done, a lot of it via WebEx and other form of Zoom type meetings and things like this, it has been absolutely an inspiration. So rest assured, every bit of energy that can be poured into this is being poured into it.
Thanks for that update. I want to talk just briefly about the diagnostic testing before taking questions. So just to set the stage about what's been happening. So the nasal swabs that you've heard us talk about over the last several weeks that get sent to the lab, LabCorp or a lab at the health department or in one of the health systems, that test is looking to detect actual viral particles, the RNA of the virus. And that's why you really need a good nasal swab to do that. That test, depending on the quality of the swab and the test itself, the reports really are that there's a 25 to 30% false negative result, meaning that the person still can have viral particles and be infected and the test still be wrong. So it's not a perfect test, but it has been done, and that's been the mainstay right now. What I mentioned to you earlier in this, is the antibody testing, and I want to explain that that's really different. So when you're measuring an antibody, that is your body's response to having the presence of the COVID virus, the RNA particles circulating. Your body has an immune response, and the first thing that your body does is produce antibodies called IgM antibodies. Those are the early antibodies that we see during an infection with not just COVID, but with all kinds of other infections. And so that's the acute antibody. Long-term protective antibodies are IgG antibodies, and they develop much later. And so I want you to think about this, which is this testing, when it becomes available, and I'm actually, based on the news reports today, very encouraged that this will be available much faster for the public and for healthcare workers, which will really positively impact care much sooner than I had anticipated. So I'm hoping in the coming days, weeks, months, and that it will actually impact care during this crisis. But if you think about it, if we can do a rapid antibody test, much like doing a pregnancy test or a rapid flu test in the office with a small sample of blood, and we can detect whether or not someone has the IgM or the IgG antibodies, we can actually tell if someone has acute infection, if they have only IgM antibodies, or if they have had past infection, which is IgG antibodies. And you can think about it. If someone, any of us, has measurable levels of IgG antibodies, that tells us that we are someone who's had an asymptomatic infection and we're actually protected. So if you're thinking about what's happening at the Duke Convention Center, for example, it would be wonderful if we're at a peak number of cases. We're having to have patients with COVID at Duke Energy. If we could identify those healthcare providers who've already been exposed, because those should be the people that would really be on the front line. And I don't know at all yet that the test will be available locally or that widespread to be able to test healthcare workers or the public, but that's where it's hopefully going very quickly. So for example, even testing all of us, general community members, right? If you knew that you had positive IgG antibodies and you had been one of those people who had an asymptomatic infection, you would have to worry vastly less. You wouldn't have to worry really about social distancing, right? Because you know that your infection, you're beyond that. Now, it's not perfect. The IgM antibodies take some days to develop. So the problem with it is you could do an antibody test, not the swab to detect the actual virus, an antibody test and have it be negative. That does not completely ensure that you're not even actively infected, right? Because we know that even before symptoms, you shed virus, and in an asymptomatic infection, even before you produce the IgM antibodies, you will have many days, probably a week, before you even start to mount that IgM antibody response. And so a negative test doesn't confirm that you're infected, but a negative test, I think for all of us and for healthcare workers, would at least mean we know we haven't had it, so we know we're not protected yet, and we're still at risk. And so that would be really helpful information, and I'm really hoping that in the days to weeks to come with this new FDA emergency use authorization that we will have that test available for all of you in the community and for all of the healthcare workers across the U.S. You know, this will quickly scale in the coming weeks or months.
I would comment that one of the things you said first, Lisa, about the false negative rate of the nasopharyngeal swab is something that you have to worry about. And that's why I worry a great deal about these test-at-home kits. As we've said on previous FaceTime lives, when we do that test, it is uncomfortable. Like 7 syllables, uncomfortable. And I just worry that people aren't going to get an adequate sample, and then they're going to get a false sense of security that they don't have it, and that would be unfortunate.
Now, again, if there was a way, if these antibody testing becomes easy to do with a pinprick or something to do at home, that would be
totally different animal.
Different. But again, so I guess Art's really inspired by what's going on here locally, as I am. But I think, for all of the problems nationally, and what I would tell you is I believe a slow response, I think out of this crisis there are many things good that are going to come in terms of streamlining our operations and really taking a critical look so that this isn't as bad in the future, and how to ramp up, for example, developing a vaccine, or ramp up developing testing in a way that we have never really been forced to do before. So the silver lining always comes. We are seeing talk now about virus droplets hanging in the air outside that should dissipate better than indoors. Concerning now about being in a space where a person with virus has been. Thoughts and any idea how long the droplets inside stay?
Well, the data is still pretty good. The 6-foot distancing really is the concept of what respiratory droplets typically do in terms of falling to the ground. I mean, gravity's out there. That's part of what I deal with every day in the emergency department. Gravity generates my business. But it's also true for droplets. And there's a concern about these aerosolized particles that stay longer. There's a difference between detecting particles and them having the ability to transmit virus. Is it zero possibility? No. But is it very, very low after a 6-foot radius? It really is. And outdoors, hard to imagine how it's going to be a big problem if you're at any part. Now, if you've got 10,000 people in a square all hanging out together and they're close to each other, I don't care if you're outdoors. But the data on the respiratory droplets comes from long before this crisis.
So I think some of that I have read about that is there is a possibility that there's some lingering and airborne more than just the droplets, I think. One of the cases was in the California area in that choir where literally no one there had symptoms at all. And I think it's upwards of 45 people are infected that were in choir practice together. So a huge number. And again, is that one person that was spraying droplets? I think it's hard to know, but certainly that was a very high percentage of infectivity that everybody's concerned about. When is Dr. P going to become Mr. Medicine? Okay, that's really funny.
That's actually,
He is Mr. Medicine, just so you know.
that's very funny.
If stay-at-home and social distancing are helping, why are we still expecting a surge in the number of cases?
That's great.
So really it has to do with the fact that there really is a lag, right? So we think it's 14 days before you will see symptoms and obvious infection in the patients that have been exposed. The other thing is that even though we're social distancing, the exposure is not zero, right? So we have done a really good job in Ohio, I can tell you. I mean, just look, if you really go in, and there's just great data out there in graphs, if you look at the rate of increase from states that have similar numbers to us versus our state and the rate of increase each day, it's just dramatic that ours are blunted. So that's why we are dropping down in Ohio where we rank in terms of the 50 states, and other states are going ahead of us, right? So it's definitely working, but the problem is it's still math, right? Which is it's not zero cases are being transmitted. It's just the social distancing is really decreasing the number of cases. And so again, it is working. I mean, I think when this first started and we were really doing the math, the numbers of people that were going to be infected by the end of this are vastly higher than what I think they're going to turn out to be, right? So if we were estimating of our 350 million population in the United States, if even 20 or 30% were going to be infected, and then 1% of those were going to die, we were looking at a million deaths, and we're now looking at, I hope, less than 100,000 deaths. I wish it was zero, but clearly it's not going to be. It's not zero already. So again, I think everyone who's suffering with the social distancing, and I think it's hard on all of us, and it's certainly hard on the economy and everybody who's a worker, you really have to take stock in the fact that I think this has worked clearly. If we were going to have 1 million deaths and we get away with having 90,000 deaths, we have made a huge impact, and it really will all have been worth it. And again, 1 million deaths would have overwhelmed the healthcare system, and so it not only would have been 1 million deaths related to COVID, it would have been all of the other deaths related to people that couldn't have access to care. So it's my pitch for really saying I believe in the social distancing and that this needs to keep going, even though I think the peak is going to be less and better in the state of Ohio, and the numbers are lower across the U.S.
But it's still going to be a while. Weeks, plural, multiple.
To homemade mask or not to homemade mask? Okay, so the cloth masks, or what you've heard the president talk about, scarves, again, the World Health Organization still does not say that that's what we should be doing, but there is a lot of interest in this now, thinking about what's going to happen as we're on the other side of the curve and it's going down, but it's not zero. What stay-at-home cloth masks do, and scarves, is prevent the person who's wearing it. So if I'm wearing a mask, preventing me from spreading droplets or aerosolizing particles that contain virus into people around me. And so I think there probably will be the recommendation for us to wear masks when we're in public places as this epidemic winds down. And there is data that the cloth masks are effective, and so the homemade masks I think are okay.
Yeah, as long as we understand the directionality of it.
Right. It's not protecting you from getting exposed. If they are getting ready to tell us all to wear masks, how in the world will we find any? Well, this goes back to, I think, there's lots of videos out there. I actually have friends and colleagues, physicians who are seamstresses who are making them all now. There's some great videos out there, and I think they are really easy to make. I'll make a pitch for Carrie Rickenbaugh, who's the woman who knows how to do everything, who is sewing them, and maybe she'll take an order for you. But I think we all can make them, and hopefully the supply really is coming of really surgical masks for all of us that will be more available.
Yeah, there's a new term out there called stress sewing. Keep it up.
I still can't understand how wearing a mask keeps you from spreading the virus, but it won't help protect you from it. If it can't get out when you cough, why is it that it can get in when someone else coughs? Thank you. Bye.
Well, I mean, so might it help to some extent? Maybe. But the other thing is people don't realize is when I'm working clinically, I don't have just a mask. I also have eye shield. And the other thing is if the particles are out there and they get on your mask and you take that mask off and then touch your hand to your face or your eyes or your mouth, that you are still getting exposure, right? If all of us had a mask and none of us were coughing it up, there'd be less exposure. But when we in healthcare are taking off our masks or any of our protective gear, we have to be extraordinarily careful. So it might help you from breathing in that particle. That would be logical. But if you're breathing and those particles are on your mask, and these masks, frankly, they're often moist, right? Imagine breathing through your scarf in the wintertime. That gets moist, and a moist protective mask is not terribly helpful for you. But again, it's your eyes, which are just as vulnerable to particulate. And basically, it's getting in the air and getting on your hands, and then you're infecting yourself by touching your eyes, nose, or face.
The other thing it is remember that the viral particles do live for some period of time, and it's been variable what you hear, 24 hours, 3 days, depending on if it's cardboard or what type of surface it is. So if a person who is shedding virus is in a area in a grocery store using a cart in a grocery store, has particles on their hand, leaves them on whatever surface it is, and then you walk in wearing a mask, but you are using that cart, you take your mask off, you touch particles to your mouth, that's the way that it's transmitted. So it's not protecting you from, and again, with the limitations that Art just said, with particles being coughed at you because the person across from you is also wearing a mask, but it's the possibility of all of the droplets being on other surfaces and you touching your mask again, which is why even if we all are wearing a mask, this is one of the things that they talk about on the news. Sanjay Gupta talks about a lot about his concerns about the mask policy, which is that it makes us all less thoughtful about hand washing, right? Because you have a false sense of protection that wearing the mask is protective. So it really goes to wearing the mask to protect others from you shedding virus and continuing to be really aggressive about hand washing. And I hope that helps.
Here's the vector of transmission right here.
Oh, stress sewing is much better for you than stress eating. Well, that is from a colleague who I know very well, who I agree with you 100%. That's great. And I predict that you, my friend, are making them too. All right. Any other questions today? Well, you have my husband. He won't be here tomorrow. Let's see.
I don't think next week either, as I'm spending 3 of my 5 days next week in the ED. So.
All right. So again, tomorrow on the Ms. Medicine Facebook Live, I have Dr. Lori Burkholtz, who is my newest partner in Holland, Michigan, will be joining us. And she's, again, exercise physiologist, really all about nutrition. She's amazing. Hope you'll join us for that at 11. And then I'll be back at 3 with the usual update tomorrow. So I hope everybody has a great day. Thank you for joining.